Happy day to all. This is Dr. Nivedita, co-founder and chief physiotherapist of Sri Ahana Physiotherapy Clinic and Academy. This video is on causes and clinical implications of scapular dyskinesia. We all know that scapular dyskinesia is the loss of control and motion of scapula. Factors like postural abnormality, nerve injury, capsular flexibility, muscle imbalance and proprioceptive dysfunction can cause this. Under postural abnormality, increased cervical lordosis or thoracic kyphosis will disrupt the normal resting position of the scapula. It leads to excessive protraction and acromial depression. When there is clavicular fracture, it shortens or angulates the clavicle. It thereby alters the ability of the clavicle to posteriorly rotate during overhead movements. Whenever you do overhead flexion or abduction, the clavicle has to posteriorly rotate. So this movement will be hindered. This posterior clavicular rotation permits initial and final 30 degrees of scapular rotation. When there is disruption in this, it leads to scapular dyskinesis. When there is acromioclavicular joint injury or anatomical anomalies, it will result in scapular dyskinesis, as the AC joint movement is important for overhead movements. Under nerve injury, we can see that it happens during surgical procedures or in case of neuropraxia or traction. The spinal accessory nerve palsy, we can see the trapezius weakness where there is depression and lateral translation of the scapula as seen in the image. Under long thoracic nerve palsy, there is serratus anterior weakness. The scapula is superiorly and medially translated, which is clearly visible in the image. Next, we have the dorsal scapular nerve palsy where there is rhomboids weakness. Here again the depression and lateral translation of the scapula occurs, and also pain and tenderness is found along the vertebral border with or without muscular atrophy. Lack of muscular or capsular flexibility or contracture. Tightness in pectoralis minor or shorted of biceps tilts the scapula anteriorly because of its attachment to the coracoid process. Next is the tightness in pectoralis major. It restricts the posterior clavicle tilt and it also affects the normal scapular movement. Once the clavicular posterior tilt is restricted, the scapular rotation is also restricted. So this results in scapular dyskinesis. We have the lack of muscular or capsular flexibility or contracture. When there is glenohumeral internal rotation deficit because of the posterior capsular tightness, there is anterior and superior translation of the humeral head. There is loss of internal rotation resulting in altered scapular movements. Under muscle imbalance or weakness, when the scapular muscle fatigue occurs, altered glenohumeral joint movements happens. According to Sherry's law of reciprocal inhibition, if a muscle is continuously recruited in an abnormal pattern, like in forward head posture, the antagonist becomes inhibited due to receiving continuous inhibitory impulse. Most commonly inhibited or weak muscles are the serratus anterior, the lower and middle trapezius and the rhomboids. Proprioception is the ability to detect static or dynamic position of limb in space. Injury to a joint alters the information from mechanoreceptors. They sense the mechanical deformation of the soft tissue. Direct physical trauma to the ligament or capsule will disrupt the message to and from the joint, resulting in proprioceptive loss. Inhibition is seen as the reduced ability of muscle to exert torque, reduced ability to stabilize the scapula, disorientation of normal firing patterns, and more commonly the serratus anterior and lower trapezius are affected first. Indirect disruption may result from effusion or hemarthrosis. Sensory receptors will remain intact, but they produce incorrect information due to the increased pressure that they face. Coming to the most important clinical implications of the glenohumeral pathologies and shoulder pain. There is abnormal scapular movement. There is altered glenohumeral relationship. Excessive demands on the static stabilizers is being put and there occurs wear and tear of them. And this causes excessive shearing around the joint and there is more demand for the rotator cuff. When there is more demand for the rotator cuff, it causes muscle overuse, fatigue and insufficiency. And it leads to abnormal biomechanics of the glenohumeral joint, thereby causing glenohumeral pathologies and shoulder pain. I request you all So it is very important to note the abnormal scapular movements and correct them, because that reduces the demand on the static stabilizers and also the rotator cuff. To understand this concept better, kindly watch our video on glenohumeral static stabilization. Thank you.